So we're going to do now is have a segment on supervision, and I'm sure many of us in the audience had the experience of being supervised by Dr. Havens, and if you didn't, maybe this is a way of conveying some of what that was like for you. And so we're going to have Todd Griswold is going to do the first little segment, then Alyssa will come back up, and then Tom Lavin here will come up and do his presentation. After which we'll have a little panel discussion around that, and then I'd like all the presenters to come back up and really open it up to questions from the audience. So be cogitating on your questions. So Todd, please get us started.
Well, I guess to set out the background first, I trained in adult psychiatry at Cambridge Hospital when Les was training director from 1989 to 1992. So that was when I sort of saw the most of Les and learned the most from him. During my last year, he was a psychotherapy supervisor of mine, which I was delighted to meet with him weekly. And then we had lunch pretty regularly for some years afterward. And, I had some prepared remarks, and then I thought I should just speak spontaneously about how I'm feeling, and then I thought that's going to be too sentimental, and this should be a little more academic. And I thought, but I don't know, there's family here, and so bear with a somewhat mixed up organization and presentation here, but I think that, I was really moved when someone spoke earlier and said, Les saved me, or had a description of what an impact he'd had on them. So I was as miserable as could be in medical school, and when I got to, psychiatry was fascinating, but when I got to residency, it wasn't that much better, except the patients were fascinating. My colleagues among the resident colleagues were great. I had some really good faculty. But I was quite anxious with supervisors and faculty. I was pretty aloof. I was worried that I didn't really know what I was doing. I was too obsessional. I didn't really know much about feelings. I wasn't going to be able to do this. So I kind of kept my distance, and somehow Les became a mentor, the only faculty person I've ever felt sort of magnetically pulled toward and influenced by, and it's partly his phenomenal nature and partly my inability to do that in many different circumstances. So it was really very important to me, and so seeing him teaching is quite moving for me. And I'm telling myself what I really want to try to convey to everybody is the excitement and the vitality and the fun. Alex was talking about fun, and you see him when he's teaching. I mean, it is phenomenal. His brilliance, his improvisation, the way that he's like the ice shaft for the educator is boredom. So he just takes it on, throws that joke out there, and gets everyone laughing. And so he's so brilliantly skilled. Yet he could also be very subtle in supervision. So it was a delight to meet with him weekly. And it was a very special time to share the difficulties with cases and the difficulties that I might be having. And he would, in his remarkable way, be helpful constructively. Like, not you need a divorce. I didn't need a divorce lawyer then, but, helpful in practical ways, but also helpful theoretically, and just through the field effects, his magnetism, his ability to give me enough space and not to get in too close was just great. So I think the supervision experience with him was remarkable and formative. I do want to tell a story about something that occurred probably around 1992, because I found the journal article. But this has to do with what we've been talking about, biology, or different biology versus psychology, the different paradigms. So there was an article that came out in 1992, I think it was in the archives of general psychiatry, it was a neuroimaging article. So it was a PET scan of people with OCD. And it looked at people with OCD who'd gotten better with psychotherapy, and people with OCD before treatment, and then people who got better with psychotherapy, which was CBT, people who got better with Prozac medication, which was Prozac, and then comparing the images. And what the images showed is that there were, in PET scans, there were imaging changes visible in the brain, and that the changes looked identical, whether someone had received CBT or medication. Now, this blew all of our minds. Nowadays, it's sort of like, oh, yeah, that kind of makes sense. Yeah, I mean, we're much more sophisticated in our thinking, but it was mind-blowing then. And so one of the residents was quite animated in describing this study to Les, and sort of thrilled with the neuroimaging aspect and really wanting, to sort of impress Les, like, look at what this can do. And Les he hadn't read the article, but he's like nodding about the PET scan, and he said, that is extraordinary. That's remarkable. That's extraordinary. He said, you know what I would do if I had one of those machines? I would put one of my patients in there, put him in the machine, and then sequentially, one by one, I would march in front of them, each one of their family members, to determine which family member is driving them crazy. And this was Les. I mean, that is so brilliant. It's funny, it flips the paradigm, it throws you completely off balance. You realize, wow, he would ask us, where do you locate the pathology? He'd often ask us that. So the MRI is like, well, if we look in the brain, we'll find the pathology. That's the whole thing about the imaging. It's in the brain, find it, look for it there. And he just pulled the rug out from under us, made us laugh. It was just really wonderful learning from him. So that kind of mind-opening thing that he could do was remarkable. One other aspect of his supervision that I don't think I'll be able to convey as well, but it's a sense that when you saw him with patients or when he was supervising you, the sense that he stood for something. That some people said he was an activist, but he stood for something. There was a sense that he was taking a principled stand against something maybe, or for something. He could do it on behalf of patients. He could do it on behalf of you as a trainee. He had a kind of principled charging forth into the world in a subtle way. And it was very opening for me. Early on, I think the main thing I was focusing on in residency was, can I get along with patients? So alliance. So I was working on the alliance. So I was mostly trying not to say something wrong, make the patient mad at me, make some gaffe. So I was feeling like I kind of got good at that. Like I could actually sit with a variety of patients, and they didn't fire me, and it seemed to be going okay. And then Les started sort of leaning over to me, and he said, what are you trying to do? I thought to myself, I didn't know you actually need to do something in psychotherapy. I thought all you have to do is like make the relationship work, and then that's it, and people just somehow get better. So he picked up that there was this kind of reluctance or passivity, when I get judgmental about it, but like I needed some help thinking through, okay, now how do I want to try to help this person? How could I help move them? What should I take a stand for or against? So he really helped me do that without shaming me, without having me feel awful, really helping me think, wow, I'm really not doing that much. And just get me puzzling about what it means to do. Because I thought, being with is the highest ideal. It's pretty high ideal, but you can do stuff too. So those are just two examples of supervision with Les. Thank you. One other thing. Unfortunately, I need to leave to catch a flight.
not because of something I said, I hope. I'm very emotional, so I probably will just read what I prepared, but I think this has just been really just such a wonderful experience to just bring Les alive again. I have to say to his family a great apology, because with all the time he spent meeting with all of us weekly, monthly, yearly, every minute, having lunch, I don't know when he, I don't know. Okay. All right, because he was also seeing patients, you know. It's kind of amazing, and we're not the only ones. Hope it was enough. I'm starting to feel guilty. Anyway, I knew Les for close to 30 years, first as a teacher from afar, and then subsequently as a supervisor, at least weekly for a long time, years, and then monthly for years. He was so generous that way and so generative. He really wanted to figure out a way for everyone to succeed and be on a path. And finally, in his much later life, I thought of him as more of a friend. I think of my supervision with Les as having occurred in 4 stages. Think of the first one as the rage stage, then one I call parlor tricks, the third confidence building, and then paradigm shift. As to the rage stage, my first encounter with Les when I was doing a medical student rotation at the old Mass Mental Hospital, yeah, he got us all early, left me infuriated with him. I had no clue what he was up to when he interviewed the 2 patients presented, and I saw him as arrogant and presumptuous. It didn't help that the second patient was sociopathic, a characteristic I clearly had missed, so I was unaware that what seemed confrontational and unkind on Les's part was an effort to expose behavior that had actually victimized other vulnerable patients on the ward. The first patient, though, with whom I worked many years later, a few years later, at Met State Hospital, was another story entirely. She began the interview in dense silence, posed in a near catatonic state. Les dealt with this by launching into an eloquent speech about the nature of love. I wish I could reproduce it here, but I lack his stage presence. He said something along the lines of, "Love is a funny thing. Some people never fall in love. Others fall in love over and over again. Still others only fall in love once in a lifetime." Well, by the time this rather hypnotic speech was into its 3rd or 4th sentence, the patient unwound herself from her stance and proceeded to peer at this strange man who was so unlike all the other doctors who were poking and prying at her. It was a bit like watching a statue unfold. Well, I had a chip on my shoulder then, I probably still do, and I thought he was being manipulative and messing with her head. But at least 3 things are noteworthy. It certainly got her attention and engaged her. Second, I remember this intervention all of these years later so vividly, as do we all remember these things. That was his brilliance as a teacher. And lastly, while I had no clue what Les was up to in the moment, his approach was actually very helpful to me clinically when she was admitted to Met State Hospital some years later, where I worked for a few years then. She had flung herself out of a tree. It was an attempt at suicide in the face of unrequited love. And the day after admission, she declared herself just fine, thank you very much. She'd only been climbing the tree to get a better view. Fortunately, she wasn't physically harmed. And, well, I suppose nowadays in the managed care era, that would be it. You know, you could write down you could electronically write on the form that she was fine, said she wasn't suicidal, send her home. But in those days, we got to keep her long enough so that she could at least begin to articulate and figure out, you know, the kind of thing that had led her to be so self-destructive in the face of something that had hurt her already. And actually, you know, because it's a funny system, Cambridge Hospital, you kind of hear things. And so she lived many years after that, and she wasn't hospitalized most of that time, and she had a lovely team, I think through ACS and those who know Cambridge Hospital. She had a boyfriend, I think it was a long-term partner. They're both gone now, but it was a good outcome. And it was very helpful to not just say, well, here's this almost catatonic person who doesn't talk. As to the second stage, it took me a very long time to absorb what Les was up to in any meaningful way. and my first attempts as a PGY2 in the old Cambridge Hospital emergency room were wholesale and mechanistic. I was a very long way from finding my own voice as a therapist, but I wasn't too bad at mimicking what I admired. And Les's technique, if seen as such, can function as a kind of parlor trick, and a very dramatic one at that. I remember once, for example, the police brought in a very disheveled, psychotic man with long, matted hair, carrying volumes of written material, ranting nonstop. It seemed, though, that in no time at all we were sitting side by side, the handcuffs were gone, we were looking together at the world filled with social injustice and despotic authority. It wasn't today, but it was still bad. By the time I had filled out the pink paper and he was being led off once again against his will, we passed for the best of friends with the same world vision. He clearly saw me sign the papers, but he reassured me, "Don't worry, Doc, they made you do it." And he made me the guardian of his written volumes. Needless to say, although the superficial goal of getting him to go to the hospital had been accomplished without bloodshed, I was left feeling a lot of guilt at having betrayed this honest and innocent, if crazy, man. Maybe the worst aspect of his craziness was that he trusted me, and Les taught us a lot about psychosis and how it functioned and how it left people feeling unprotected, especially paranoid people who could be incredibly gullible. And I think one of the theories was that they were just so prone to gullibility that they almost had to develop this layer of craziness to protect themselves in the world. And this sort of gross application of Les's work could backfire if it was entered into abruptly without preamble. I remember well, for example, a chronically psychotic man with whom I had worked for quite some time when he had an acute worsening of what I would characterize as apartment paranoia. Probably many of us have worked with people who finally get an apartment in a safe place that might even have some supervision, some staff who comes in the basement occasionally or something. And he was living in this place, and he was fine for a while, and then he got more and more paranoid about his neighbors. So that was a real crisis, because I was afraid he'd be homeless again. So I presented him to Les, and I promise you it was nothing Les told me to do. But after presenting him, I somehow had the idea that I would literally move the furniture around the room so the chairs would be side by side. Well, if the paranoia had not previously existed in the space between us, it certainly took up housekeeping for a bit after that session. All I remember of the moment was the patient demanding fearfully and angrily what exactly had I in mind when I changed the position of the chairs. Moving into what I would characterize as the confidence-building stage of the supervision. Although Les was never my therapist, I think in retrospect he had an agenda with me. Although he had a biting humor and could be quite intimidating if he was faced with what he saw as therapeutic arrogance, my memories of many, many hours of presenting to him are filled exclusively with encouraging grunts, very few explicit suggestions, and no criticism whatsoever. Once, when I presented a very messy treatment which featured communication by written diagrams and word salad over long months with a schizophrenic young man, Les turned, by the way, a refugee from McLean to Met State when his insurance ran out, Les turned to our supervision group and said, "How wonderful, she presents like Sullivan." How is that for what he would call performative speech? Les, in my opinion, was a master of CBT and DBT before they were invented, particularly DBT with its emphasis on acceptance without resignation. I think that's the key. And I think 12-Step does that beautifully. It's character transforming. Les's work was character transforming. The final and longest stage of my supervision with Les I see as a true paradigm shift. Over many years, my interactions with Les were frequent and took many forms. He was an incredibly generous teacher. Once we conducted a kind of mother-father treatment, which was not unheard of in those days, with a brilliant and chronically psychotic man. Les would see him one week, I would see him the other week, and then we would confer about how things were going from time to time. I saw Les individually and in group supervision. He was often to be found wandering the wards on Cahill at Cambridge Hospital or the Cambridge Somerville unit at Met State. And there were many lectures, grand rounds, patient consultation interviews, and his wonderful books, which were hot off the presses. little by little, as I absorbed his teachings, a paradigm shift occurred, and I can truly say that his wisdom accompanies me not only in my clinical work, but in all the interpersonal interactions of my life, really.
I have a few slides that I'd like to show. Well, I'm the odd duck on this faculty. I'm the only non-physician, the only non-psychiatrist. And I feel when Bob Childs reached out to me, invited me to participate, I felt very honored and very humbled. Well, actually, that's not exactly the truth. Humbled is a euphemism. My internal response, once I saw the lineup of who else was going to be presenting, was, oh shit. What have I gotten myself into, and how do I get out of it this time? Which has been a recurring theme at different points in my life. So I think it's too late to get out of it, but let's see where we go. I want to tell you how I came to make contact with Les. I was working in the counseling center at Rhode Island College, and around 1989, a colleague, Dr. Andrea Cousins, an MSPP alum, had a copy of his relatively new book, Making Contact, and loaned it to me and said, Tom, I think you might like this. So I took it and read it, and I didn't like it. I loved it. I was at a point in my clinical work where I was feeling a bit stagnant. I was about 11 years out of graduate school. And I had an upcoming sabbatical that I was eligible for, and I was looking for a way to spend it that would be helpful and useful for me. It occurred to me that I would love to train with Les Havens. So it was really a shot in the dark. I wrote him a letter. And much to my surprise, he wrote back, first of all, and then said, let's get together and see what we can work out. So that began 3 or 4 years of supervision. That first year while I was on sabbatical, I saw him every other week. I also had the opportunity, really a wonderful opportunity, to see him do some of the things we've seen him do in the videos today. I would go to Cahill 4, the inpatient unit, where a resident or a staff member would present a patient. Les would make a few remarks before they brought the patient in. He'd sit with the patient for about 20 minutes, and he was anesthetizing them. He was building the relationship. He was, making them comfortable, as we've heard earlier today. And then he would dismiss them, and he didn't do anything, but he was laying the groundwork. Okay, and then after the patient had left, he would sort of wax on. He'd come up with these brilliant observations. He'd bring in philosophy and history and Cézanne and Nietzsche, as Alex was saying. I read everything that I could get my hands on that he had read. I went to every lecture or conference that I could find. I was at the 92 series, Alex, in the Mock Center when he talked about perspectives being the essence of the psychological and how we inevitably collide and how we need psychological analgesics to soften the pain. I wanted to be Les Havens. That's not what he wanted. He wanted, I think for all of us, not to be him, but to become the best of ourselves that we could. So he was elusive, I think, often in his work, at least with me. I was an early and eager adapter of what I read and what I saw him do. I would try imitative language. I'm not sure we've heard a lot about imitative language. He regarded that as a form of empathic speech, where the therapist gives voice to what the patient is not saying, but what the therapist imagines the patient might be thinking or feeling. For example, what do I want? And that's the therapist using the pronoun I as if speaking for the patient. And he could do that with such nuance. He talked about Sullivan being able to strike different words like different musical chords. The nuance was incredible. What do I want? What do I want? What do I want? Each has a slightly different feel to it. So I was trying that out. I was making grunts and noises like he talked about, empathic exclamations, projective and counterprojective remarks, performatives of admiration. And it did seem to me that my work was getting a bit better, that the patients were responding a bit better. The topic we're assigned is to talk about Les's supervision style. And I am not aware of Les having written or said a lot about supervision per se. Some of you may have heard or read more than I have. But I think his supervision style was very much aligned with his ideas about therapy and about treatment. And I think we can take some of those ideas and infer, extrapolate, glean what he might have thought about supervision. In his Approaches to the Mind book, he quotes Harry Stack Sullivan as saying, "For all I know, human beings have as many personalities as they have interpersonal relationships." Well, for all I know, Les Havens may have had as many supervisory styles as he had supervisees, because the whole thing with Les was about individualizing the work to fit the individual, apprehending the reality, the emotional reality of who is this person that I'm sitting with, and creating a space for that to emerge. So there are a few things that Les used to talk about that are perhaps along that line. He loved to tell the story of Red Auerbach, the legendary coach and general manager later in his career of the Boston Celtics, who brought together this disparate group of athletes, Dave Cowens, Bill Russell, Bob Cousy, Larry Bird, and somehow turned them into this dynasty that won championship after championship. So once he said, Les would say, a reporter asked Auerbach what was the secret to his success, what was his genius. And Auerbach said, "It's simple. You just have to know who to kiss and who to kick." And I think probably that's how Les might have thought about supervision. You had to know who to kiss and who to kick. I will say that most of the time my experience with Les in supervision was of being kissed. But I have at least one situation I remember fairly clearly that I'll talk about in a moment, where it was the other thing. Another thing Les used to say or write with some frequency was that he thought every trainee, every therapist is naturally, temperamentally drawn to one of those 4 schools of therapy that Alex talked about: the medical, the psychoanalytic, the existential, the interpersonal. And the supervisor's job was to recognize what that natural proclivity was, to celebrate it, but then to try to gently help them expand so that they could provide the type of therapy that the patient needed, not the type of therapy that the therapist preferred to do. Let me see where I am here. Les, I think, again, this is in the Approaches book, wrote, psychotherapy is a clinical art with scientific aspirations. So he would wonder aloud, how do we teach art? how do we teach therapy if there's some overlap there? He talked about having patients who had gone to art school and did not have a great experience. He felt or heard them express the experience that their art teachers had tried to mold them to see the way they saw, to do things the way they did. And translating that into some wisdom about how we teach therapists, this is what Les said he would say to other supervisors at Cambridge Hospital. I'll let you just read that. So again, Les did not want to produce clones of himself. He wanted to help people develop. Oops. Jay? Is Jay around? Thank you. Yep. Okay. The last thing that occurs to me that may have some relevance for Les's ideas about supervision is the idea that supervision, like therapy, is an inherently disorganizing experience. The supervisee is always under the microscope, and as Todd alluded to in his remarks, trying to protect his self-esteem. Okay, there's a power differential, and Les talked about this in therapy as the psychoanalytic asymmetry, that the therapist, the doctor, the supervisor, by extension, is always presumed to be not only smarter, but healthier and wiser. Okay, so we've heard some of this said already today, Les's work was about trying to level the playing field. He called it democratizing the treatment, and I don't know, to some degree perhaps democratizing the therapy. I think we didn't hear a lot of detail today about the psychological analgesics Les wrote and talked about in the book he co-edited with Alex. But I think in his supervision, he was very attentive to applying those psychological analgesics to the supervisee to create a space that could become safe for them. So what did he actually do? And what was supervision actually like with him, for me? And it may have been different for those of you who had supervision with him. This is typically how my hour with him would go. Actually, if I back up to that picture, that is just a wonderful representation of how I remember Les looking and what he was doing during the supervision hour. I'd come in and present a case. I'd bring in every piece of data that I could possibly think of. You know, I was seeing every tree but not seeing seeing the forest, or seeing the trees but not the forest. Les would occasionally jot something down, and towards the end of the hour, he would make a few comments that helped pull things into perspective for me. So I want to show you some things that he actually said for two of these cases. This first one is a young man, I'm calling him Ted, single, white, gay male, whose presenting problem was road rage. He was commuting to Boston, I think from Rhode Island. I was working in Rhode Island at the time. And on 95, he was getting into these situations where if someone cut him off, he would get on their tail and, you know, they'd be going back and forth, engaging in obscene gestures towards one another, or, you know, someone would tailgate him and he wouldn't get over. It's lucky that he wasn't killed or killed somebody else. And that was his presenting problem. And I can't give you the whole case, obviously, in a couple of minutes, but the context of this case was that he had suffered physical and emotional abuse as a child, felt very different, was teased and bullied. Here are some of the things Les said about him, or said to me. Again, I'm just going to let you read those. And this last one, we've heard a lot about this, make him feel good about himself. When I heard that, I want to tell you my internal response was, what? Is that all you got, Havens? Of course, I didn't vocalize this. I was too afraid of him to do that. But it was as if I was not hearing or seeing this brilliant guy whose books I had read, who I'd seen interview patients. It was like, I think someone said this morning, the interview reminded them of him being like Fred Rogers, Mr. Rogers. You know, just this ordinary, kind, friendly person, okay? And I was looking, it's clear to me in retrospect, for some sort of mutative, brilliant interpretation that over the years Les was able to disabuse me of the value of. So the next one is really, was a difficult case for me. I was working at a private psychiatric clinic in Providence. This is a 22-year-old young woman who really was depressed, angry, as it says there, was living with her parents, and no one got along in the house. And she felt unwanted and unwelcomed, especially by her father. Okay? There was some talk of suicide. There had been some obviously unsuccessful gestures or attempts in prior years. And about 3 weeks after she saw the psychiatrist who was prescribing for her, she cut her wrists and was hospitalized. The psychiatrist really pressured her into therapy, to talk therapy. She really wanted nothing to do with it. And throughout the sessions I had with her, which were few in number, she fired me after the 5th session, I believe. She was invariably sarcastic. When I would ask her how she was doing, she would say, nifty. Or if I tried to be empathic with the way her parents were treating her, her response more than once was, shit happens. She had no interest in being there, okay? And I was at a loss. I was feeling, oh my God, what do I do? My competence was feeling on the line here. So here are some of the things Les said to me about this case. You notice there's a recurrence of fecal references throughout this presentation. I remember he used to say, borderlines are just feisty people who won't take any shit from anyone. And lastly, this issue of taking responsibility. You know, as we saw in the last video, there are some times when you really just have to, take over and you're the doctor, do something, not just create the relationship. I didn't succeed with this young woman, unfortunately, and Les warned me that might happen. At the end of my supervision about her with him, he said, you might be trying too hard. Just, do what you can do and act like it's no skin off your ass if she decides not to keep going. So what can we conclude about Les's supervision style? I think he was doing two primary things, and you may have lots of better ideas about what he was doing here, but I felt like he was helping me learn how to see. And so, in a way, it was his supervision, his capacity really to see things not only through the patient's eyes, but to see things perhaps in the context that the patient wasn't paying as much attention to. What was healthy about them? What was, their singular existence, their uniqueness? To focus on the person, not just the diagnosis or the symptoms. And I know he loved Emily Dickinson. The other thing I think he was helping me to do, and perhaps all of us to varying degrees, is to learn how to talk. And as Alyssa was talking, I think the last thing is he helped me develop more confidence by providing someone to confide in my uncertainties, my anxieties, and just how to endure and stick with it. So thank you.
So could I invite all the presenters to come up here and take a seat? And I invite all of you to think about what kinds of questions you might want to talk about in our last 45 minutes together. It's been a remarkable day in so many different ways. And I think the one thing I wanted to say was in terms of my experience of being supervised by Les, which I had the opportunity to work with him for about 10 years. Just to add an echo of what both Alyssa and Tom said, is that I always had the sense that he was talking to that emergent therapist in me that was trying so hard to find his way into his work. And he had a remarkable sense of being able to see that part of me that I couldn't see, that was on my peripheral vision. And so in terms of the seeing part, to me, it's all about learning how to see the periphery. And with that in mind, I'd like to start the question and answer period with a question to the panelists, which has to do with this, because this is something else that Les would tell me and talk about, which is that so often our fantasy is as therapists, and I think the system colludes with this very strongly in this day and age, which is the kind of the uncovering of the patient. And, a number of people have talked to that. But what Les would often say to me is, he said, the reality is it's really about the uncovering of the therapist, and that we have to sort of explore those parts of ourselves that we struggle to bring into the room and into the work. So I'd wonder if the panelists might pick that up a little bit and just get things rolling. Then I invite the rest of you, if you have a question, to come to the back of the room. Yes.
I loved those three presentations. They were just beautiful. Each person with a very different kind of perspective and what each of you was working on, and sort of the way that you all were so open. I mean, that you felt safe enough to be kind of vulnerable and authentic and real as you presented what you were working on as you developed. And then the way Les, as a skillful supervisor, received you differently. And I was also just wanted to comment that on the thing we watched before, the way Peter and Todd had talked about the way Les supervised that whole group when they were kind of going after the patient. They were going after the patient a little bit. So he gave a talk about 4 ways we tell stories that we make up about people. And are those stories really true? And maybe a saint just has more friends than they call them followers, and the other people. But just the way you guys picked all that up, and there's a kind of magic that in them, I thought Todd and Alyssa and you, Tom, were just the embodiment of people who've grown and become yourself and are safe enough and free enough to share both your vulnerability and what you've learned. And it was just really lovely to listen and just see what happened. So,
I actually have a question for the supervisees. Kind of a tough question, and maybe Alyssa, first of all, since she goes back farther, which is whether Les, as he knew you, got less prickly and more empathetic, or whether there was actually some change over time. He had some, difficult family events and also got older, and whether this was really, we're talking about the same person, in the 70s, 80s, and 90s.
Wow. It's funny because everything today has made me think in different layers about why I developed the kind of supervisory relationship I did with Les in ways that I hadn't really thought of it before. Without going into too much detail, because I'm probably going to have to sit here and hear my whole life story, but I truly think, and I've mentioned her several times today, that the bridge was Dr. Benarin. She's little known because she never wrote and she had her own struggles, but it was a very different era, I hope, I don't know. But in those days, departments of psychiatry seemed to feel they could be quite intrusive about their residents. And I even remember, and this I won't go into any detail, the most incredible set of interviews I had at Cornell before I chose Cambridge, where I think I was not really being considered in the first hour, but they kept adding more and more interviews. I don't know what I was saying to them that made them think I was finally of interest, that I could have 8 interviews instead of the one they originally arranged. In any case, at the end of the day, they pronounced that they had basically analyzed me and I was good to go. And I thought, wow, I better not go here because obviously they don't know what they're doing, so I'm not going to learn anything here. And Les, comparing that to what happened between me and Les, although actually this is weird because I really haven't thought about it in quite this way until today. My main mentor and my real inspiration for psychiatry and medical school is Doris Menzer-Benarin. I don't know if people can hear this. Doris Menzer-Benarin, sorry, I just was seeing if it was on. Anyway, she was out of commission for my PGY 1 year, I think. And somehow the Department of Psychiatry assigned Les to make sure he was going to be my mentor now. And not therapist, but mentor somehow. It was very intrusive. And I still remember the meeting with him. I had forgotten it, really. So he arranged a meeting with me. We sat down together. I asked him if Dr. Benarin was out of commission for reasons, basically, without going into any personal details, that were hopeless, in my way of thinking about it. He said no. And I said, fine. He said, the department wants me to be available to you in any way that you want me to be available to you. I said, I'm fine now. So he said he respected that. And I don't know I don't even remember if we had any interactions further during that year, but it was respecting the distance. I told him what I needed, which was nothing from him other than telling me that she was fine, and she was. And it was just very respectful. It was very different. So I think that was incredibly empathic from second one. He didn't know me. He didn't really know me at all, any more than the Cornell people knew me in their interview. Or he knew me less than they knew me. The intrusive questions they asked all day long were incredible. But anyway, so there was that. I don't know. I just never experienced a shift in the way he was with me in the supervision. He was just, I would bring him these patients. The little notebook would come out. A few things would be jotted down. Some of the things I remember aren't even very profound. I don't know if people can hear me. I don't want to make it too loud, but I remember once I was treating a patient. I think he may have referred her to me because he was treating the husband, and I was getting a little worried that I was missing the patient's anger. It was something I was very good at missing. I thought everybody was, I loved everybody. He never had to tell me to love a patient. But I couldn't sometimes see. I was blind to more complex things. But I started worrying because of something another therapist said about this patient who had had an interaction with her, that maybe I was completely blind to her anger. So I think I brought that to Les, and he proceeded to tell me that her husband, who he treated, was maybe needing her to be angry like that, and that it was good that she could be controlling because he'd never met a more controlling man than the husband, so someone had to be able to stand up to him. It was very helpful. It wasn't something that you would think of as profound, but so he didn't tell me that I couldn't love the patients. He didn't pathologize them. He just kind of encouraged me. It's funny because the whom to kiss and whom to kick person who was my supervisor was George Goethals, who told me I wasn't kicking enough, and he was right, but it wasn't Les. For some reason, he didn't feel he needed to tell me that. I learned, more subtly though. Yeah.
This just triggers a memory about something when I was leaving Cambridge Hospital going to Riggs, Austin Riggs Center, it was going to be either a 2 or 3 year fellowship in intensive dynamic therapy. And Les asked me, do you really want to go? I said, yeah, I do. I had made a deal. I wanted to go. And he said to me, will you do me a favor? And I said, what's the favor? He said, places like Riggs tend to cannibalize their young when there's a suicide. So he said, they go into a regression, get into a fight-flight group. And he said, the way to protect yourself against it is when you get out there, find one of their senior people that you like and get close to them. And when the group goes into regression, you'll be safe. Just do what I'm saying and go out and learn what you can learn. But he had this very kind of practice. He was absolutely right about what he told me, and I discovered it in how it all works in a place like that. And Riggs isn't the only place on earth that has that dynamic to it. But he just had these little touches. It was maybe a 40-second conversation, but it was with your best interest in mind. And it was like, here's where the North Star is, south, here's east, west. Take this map with you, and when it happens, you'll be okay. It was pretty lovely. And I was thinking of just the way he did things differently with Todd, or with you, or with you. We all had different personalities, but he had his methods, which were myriad. Yeah.
Peter, I wouldn't say I ever saw him prickly with me. I didn't feel exactly kicked with the second case I talked about so much as him taking me by the shoulders and shaking me and saying, Lavin, wake up, you got to pay attention to this one. And I felt like he was doing that because he wanted to protect me. And that's the sense I got that he was looking out for all of his students.
Yeah. Let me share another piece of that kiss and kick. So after my 20-year-old patient's suicide, and I felt really terrible about it, and he was very nurturing, supportive, protective. And then about 2 or 3 months later, when I was more recovered, he had a tough guy session with me, and I wasn't in supervision. I mean, I was already a clinical director of claim, but we were together, and he said, just by the way, I wanted to mention to this, haven't I taught you anything? With that, he said, with that patient of yours who killed herself, she was so unstable. And every time you met, you were meeting 2 times a week, and I know at Austin Riggs they do this, and at McLean, but you two drove each other crazy. I mean, she died because of things that happened long before you ever met her. But, what was I trying to teach you? And so there was this combination of nurturing and support, and then this other kind of pushing against when he felt like I was strong enough for that to explore the other possibility. And it also would bolster me, because if he would feel tough enough to just let me have it, I was kind of recovered enough. Do you see what I mean? Yeah. So there was this, when I was looking at the kiss and kick, I was going, oh yeah, I've got both sides of that from the coach,
And protecting the patient was first.
Yeah, right.
Protecting the resident was a close second, but protecting the patient was first.
just want to thank the panel and all the presenters for this wonderful kind of a conference. I came here, I didn't know anything about Leston Havens. I heard about him, but I just wanted to really get to know who this person was, and he came alive. He came alive in all different kind of aspects with the family and with supervision and with his style, and so that was great. And also I want to share something funny. People talked about supervision. I was in training here in the 80s when my English was very poor and I didn't know what supervision was. So in my, one of my supervisors was Justin Newmark, who always made fun of me because I said that I used to call him my supervisor. And that was my perception of what his role was for me. And so that stayed with me for years. Thank you so much.
Thank you.
I wondered if you think that aspects of Haven's approach could be used in a facility where brief treatment is mandated, maximum of 12 or even 8 sessions.
I think his treatment or his method on some level can be used all the time. It's just a way of, I mean, for example, at the Latino clinic where I work, I see a lot of new people. And from the minute, I mean, Les is by my side from the minute I'm out in the waiting room getting the person. I'm just picking up some kind of signals. The minute we're in the room, I'm picking up signals. There's some way that I'm constantly adjusting how I'm reacting by what I see in the reaction of the patient. It's a constant thing. And as far as short-term therapy with short-term goals, you know, some things can't be changed in 8 or 12 weeks. You know, character stuff, long-term things, trauma where the person needs ongoing accompaniment. But it's kind of remarkable how treating a person respectfully and listening to them and getting on their side and being trusted can at least give some relief. Maybe Soledad Vera, who's maybe next in line, could speak to this because she's a brilliant psychologist on the Latino team. But no, you can't necessarily do the earth-shaking long-term change in the short period of time, but you can make the person feel so much better about themselves. For example, in that clinic, I mean, people come in feeling like you're going to scorn them and that they're the dregs of the earth, because that's how the world is treating most of the patients we see there now. And just saying something respectful sometimes seems transformative. It's bizarre. But Les would be that way. He was always respectful with patients.
And I think also that slightly behavioral aspect of you're not crazy, they are out to get you, you need protection, is a very good short-term beginning.
Thank you. I actually was wanting to share that one of the contributions that at least were the reflections that I take away from learning more about Les Havens today is how just normalizing our craziness. And one, so the crazy, the patient, you know, things happen to people and we get crazy. And also encouraging us to see the craziness in ourselves, you know, that we're all patients, we're all human, and we're all vulnerable to. So I guess what reverberated with me throughout the day was just that. I felt, oh, he normalizes, things happen to us. Our families are crazy, and you know, to have the family members parade in front to see how the PET scans come across that. You know, in some way, he kept privileging that what's making you crazy is things or people, relationships, things that are happening. And in some way, it's a very trauma-informed, Jennifer, you had pointed that out, it's a very trauma-informed perspective. you know, good things make us feel good, bad things make us feel bad. But anyways, I walk away normalizing my own craziness, feeling, and also it's always a good reminder. Things happen, and we feel should happen. Yeah, so.
He was an early proponent of that.
Yeah, thank you. So I'd love to hear more from you all just about how that may have been part of what you weaned from him.
He never told me to lie to my supervisors, but I knew I should be careful. I think I got that from him.
He told us to make it up. He told us if you have to write a long volume on someone after you've met them for an hour, and someone gets angry at you, or it wasn't quite as insurance pressured then, but somewhat, just make it up. He said, make it up. And I can't confess this because the person who just was speaking, Soledad Vera, is maybe technically my boss in a way. She's the head of the clinical director of the Latino team. I don't really make things up in the electronic record, but, you know, I'm not going to ask all those questions. So, and I got that from Les. He's with me. Just subversive. Just if it's harmful to the patient, it's not ethical to do it. You know, do what you have to do.
Thank you. I really appreciate the opportunity to be here today. I'm also a student from William James. I'm a clinical psychology student. I got two questions. So the first one is I sometimes heard about the term ego dystonic suicidal ideation from like some of our patients, and I wonder like how would Dr. Havens or you guys think about like this term? Like how do you understand it? Like that reminds me of what we were talking earlier about hallucinations. Like how do we make meaning of that, and how do we approach it?
Could you say the
so
term, the first part of that term again?
Ego dystonic, suicidal.
Ego dystonic hallucination.
No, suicidal ideation.
Ego dystonic suicidal ideation.
When the client says that's not their thought, but then like a voice is telling them to harm themselves.
Okay.
Well, I'm no expert about this, but I remember reading some of Dan Bowie and Terry Malzberger's work around suicide, and how, you know, the question we should ask when we're working with a suicidal patient, or one of the important questions of ourselves, is there anyone who wants them to die? Because often there is, you know, there's a part, family life is difficult, their relationships are difficult, and people, even if it's not verbalized, you know, things get communicated or at least perceived. So maybe that's one way of thinking about ego dystonic suicidal hallucinations.
Yeah, I have just two associations now that he says that, and a question back. But there's a movie made by an Indian film company it's a movie in India about a rural program where people can, if they die, if the farmer will die, commit suicide, they can get some money for their family. And so the movie sort of illustrates, sort of in a social setting, the different groups. Half the people in the village are urging the guy to kill himself. It's the right thing to do, and half are saying this is a bad program, we don't think it's a good idea. But it's a real thing in a part of India, and there's a whole group of people advocating the different sides. And I remember one of our residents showed that movie in our 4 schools of psychiatry. And the discussion was about when we're down in the emergency room, this is what we're actually trying to figure out with these suicidal patients, only we don't see all the different people who are advocating for these different options. Do you see what I mean? So, you know, it's very much what Bowie and Ambler were talking about, and it's illustrated in this movie, but most of us kind of resonated with, oh yeah, that is what we're figuring out, these different voices and who's pushing for what with this person at this moment, but it just seems like an individual's there. You see what I mean? But my question back to you is, Have you seen somebody like this? Is this something you've just wondered about from something you read? I'm just curious how you're thinking about it.
I think it's just kind of, sometimes it's easier for them to say, it's not my thought, I'm not killing myself. But then like, it's kind of like socially more accepted. Like, oh, someone's telling me, like a voice is telling me.
Yeah, and that's a really beautiful observation you've got. So, I mean, how might you want to work with it to explore that further? You know, is there something you might want to say to the patient or wonder about with them? Because it sounds like you're onto something.
And you have to be careful with voices. Certainly you see this a lot with young people, both children and adolescents, where they're telling people they hear voices and, you know, they have no other indication of having a psychotic disorder. And, you know, voices alone are not a psychotic disorder, in my opinion. And usually it is a voice of someone telling them, you know, something bad about themselves, which usually tracks back to some real experience they've had. I was always struck when I was working in Washington Heights for 18 years that one of the major predictors of adolescent girls who would come in suicidal, who'd been sexually abused by someone in their family, was when their mothers blamed them. You know, and there was a direct transfer to, if their mothers believed them and understood them, they wouldn't come to the ER because they weren't suicidal, but in that circumstance, it would translate into that. So be careful with voice alone hallucinations and the diagnosis of psychosis, particularly with people who have had significant traumatic experiences, because sometimes they're that, often they're that.
My other question is, I also value the importance of understanding the person's quality of relationships. I wonder if there's any ways that you can assess it systemically in addition to just doing the interviews. I wonder if there's any other tools that you use to kind of understanding the person's functioning in relationships.
Well, that's a great thing. That's a great thing about child and adolescent work is you always see the parents, and you often see them with the child. So there it is. You're not making it up. Because when you're treating adults who you have no collateral information from, it can be quite striking. Les was always talking about his capacity to feel whether the person was in the room. You know, and I'm sure every therapist in the room has been in the room with someone who wasn't really entirely there and wasn't integrated, not in a psychotic sense, but in a characterologic sense. And it's an intuitive thing when you feel people coming into contact with you.
And Myrna Weissman, who's at Columbia, you know, has a wonderful psychotherapy that's well-researched, interpersonal psychotherapy for depression, in which you have a little inventory for the important relationships. When you ask people out, who do you spend time with, what do you want from the relationship, what not, how would you like to change it, and that becomes a kind of one of the organizing elements of your strategy in the therapy. It's a quite beautiful and evidence-based proven treatment, and that's a nice way to kind of get at those relationships with the patient.
And it's probably not too intrusive, even very early on in a first meeting, to say something along the line of, I hope there's someone in your life who knows what you're going through or who cares about you. Just not even posing it as a question, do you have friends? Which I've been, you know, you can do, but it might make a person feel ashamed that they don't. But so you can maybe get at least their sense of whether they have made a relationship or have a relationship where someone is there for them.
Thank you.
Thank you so much again. I just had a quick question about specifically with supervision when your supervisee feels that they're almost being abused is probably too strong a word, but you know, the patient, I understand the whole idea of always respect the patient, and it could be an issue with me with my lack of experience and confidence. But like I had a client this past summer who had some personality issues and became sort of semi-abusive with me, and I had to end it. And just in listening to you talk about Dr. Havens and sort of the way he was so empathic to their situation not being their fault and those kinds of things, how, as a supervisor, do you protect your supervisees with that in mind for the patient? Because, like, I understand that, but I also feel like it's a really blurry line, especially for students or residents, where how much do you take and how do you know you're taking the right amount as opposed to giving up on them? Sorry, that was kind of loaded.
I'll throw a few. So that thing, remember when he was talking about hanging up the phone? So that was a metaphor for behaviorally change the situation. So his idea was if somebody's being abusive to you on the phone, just hang it up. Say, I'm having some phone trouble today, voice comes back, still arguing, oh, more phone trouble, boom, hang up, keep doing it. When the voice starts getting nice again, wait a minute, phone's starting to work, listen a little bit, if it's changed, okay, let's talk. Right? So how do you translate that into your communication to your patient? You can be direct in words and tell them, I mean, one way to do it, a lot of times as a supervisor of people who treat a lot of patients with borderline personality disorders and anger, and they have trauma and they're transmitting all that, partly you can say to them, look, I don't want to drive you crazy, and I'm not going to let you drive me crazy. So let's just, you go first, tell me what you need from me, and I'll respect that, and I'll tell you clearly what I need from you. And if the person's, you know, however, I don't know what form of abuse, verbal abuse, derision, whatever it is that you feel is crossing the limit, you just lay that out. But I also remember in my psychoanalytic training when I was in supervision and dealing with very intense relationships with borderline patients in the Austin Riggs setting where I would see them 4 times a week, and I was in analysis one day a week. I remember my supervisor would say, he was my analyst, not my supervisor on the case, on one particular case where a young man was clearly getting very aggressive with me, and I didn't want to go to the sessions because it was so awful, and he was blaming me for everything. And I remember my analyst saying to me, you've got broad enough shoulders to bear this a bit more. If you're going to be a good psychoanalytic psychotherapist, you've got to feel what he's communicating to you. And when you've had enough, then you tell him stop it and say, that's enough. I don't know who did this to you or the exact circumstances, but I know what it feels like now, and I'm not going to take it, but let's figure that out. You see what I mean? So his idea was that the person was communicating something he needed to communicate to me. I was being asked to emotionally bear some of it, and I was jumping off the wave a little too soon it was my analyst jumping in with me, you know, helping me with this from his perspective. And those are some different things to throw into the hopper.
There's a great lecture on the website, the Leston Havens MD website. I think it's titled On Being Overwhelmed. And Les talks about how we therapists with our labels and other things can overwhelm patients, but he also talks about how patients can overwhelm us, which is what we're really talking about, hanging up the phone. Sometimes he said he would get just distracted and stop listening so closely to what the patient was saying. There was one case he talked about where the patient would come in, and the first 10 or 15 minutes of every session, the patient would just lay into Les, tell him what and Les said he tried to regard it as good practice for family life.
Yeah. And I'll just add one more thing. That particular case I cited was about an 8-year psychotherapy, and it went from a period of horribleness. Otto Kernberg actually consulted on the case and said, this man has pseudo-psychopathic schizophrenia, and he will develop a paranoid transference to you. And so Otto had his own idea about it. But I used to have those sessions for about 2 or 3 years. And then I came to really enjoy, they totally changed. And I came to enjoy the visits and I'd see him maybe 3 or 4 times a year. And then the last thing that ever happened was maybe 2 or 3 years after he left, he sent me a Christmas card. And he said, I got married, I got a job as a librarian, marriage isn't all it's cracked up to be. That's the last I heard of him. So that's a cool case. I mean,
I just want to add one more quick thing, that this case may have been a very extreme situation where the patient was just not very reachable, I don't know. But Les's writings about a counter-projection would be very helpful in getting, he saw a lot of, I can't make this work right, a lot of the times the anger as being projected onto us, and we've all had that. It's not us, they don't even know who we are practically, or if you're working with them, you're just well-meaning, you're trying to help, and the patient is enraged at you. So he had wonderful methods to get the projections off of you, out of that space, so that you were both looking at the things, sorry about this, the patient had to be angry at in the world or in their past. And the only other thing is I think it's participant observation. It's tricky, though, because sometimes a therapist has to own something they did or are doing or are ignoring, that the patient should be angry at us. And there's a beautiful example in participant observation of a therapist whose apology to the patient serves as a counter-projective communication. It's really beautiful, but anyway, so I think Les was a lot about preventing us from being in that situation.
I want to say something that's not useful, but perspectival, which is that the ethos, when I came in the 70s and when Les was there, was that there are no bad patients and everything is material. Now, this was somewhat too useful to the residencies because there was a lot of emphasis on inpatients. So you would be working with someone nearly catatonic or whatever it was, doing 3 times a week psychotherapy. And the downside was the student would be learning, that is, learning Freudian psychoanalysis, but the patient wouldn't be progressing at all. And I think what was good about Les's method was he actually intended to help. He intended to break up the log jams, have the resident be protected, and so on. I'm also saying this also thinking more about arrogance and lack of arrogance. I mean, I think Les was very self-protective. And when I said, is it the arc of his life? Is it aging? Is it how long the supervision is going on? I'm certainly open to the possibility that earlier in the supervision, or whatever you call it, with Les, I was arrogant. And, that called for one response, and as I toned it down, less. And I think that, ideally, that is how it works, that he kind of, when necessary, would, put the brakes on or give a little bit back.
Thank you very much.
Sometimes with a very angry and belligerent patient who you've just met, and you're trying to work with, if you can shift the patient into taking a history about what has either happened to them right in the moment to make them so angry and then carrying it back, you can push it out of the interaction with yourself and push it into looking at that in a way that can bring the person down. But that takes a fair amount of, I think the one thing I always feel is when a patient's making me feel anxious, I think it's because that person feels unsafe. And if you think about that, it brings your own anxiety down, and you are a little freer to work in that space. Because generally speaking, I interviewed a kid at a state hospital, another kid at a state hospital a few weeks ago who was committed against his will, and he was furious. And the first 5 minutes, he was making me really anxious. And that's a signal that he's scared and unsafe. And aggression, is the way people protect themselves when they're unsafe and hurt and angry. So if you can get your own affect under control, you can find the stuff to get to connect with the person on. And, Les's famous story about, when the person stubs their toe on the dresser, you go over and kick the dresser, right? You're siding with you know, the person against the thing that has hurt them. It's hard. I mean, it's amazingly, I think about now how we wade into these things when we're so young and we're so unskilled,
Yeah,
and somehow we survive all this, right?
I have the example for that. So as studying as a student and then being at McLean in the inpatient unit, I was told to meet a patient. And I went to meet this woman, and I went in her room, and she started yelling at me, just screaming at me. And I was overwhelmed, and I just stood there. I felt frozen, didn't know what to do. And suddenly it came out. I said, "You must be anxious." And she said in a whisper, "How did you know?" And the whole thing, brought the whole thing down. It was just incredible. But I've enjoyed this so much, and it's been very inspiring and very creative, I think, the way everybody's participated in it. And I feel the warmth of the man. I never met him. I wish I had. I feel this playfulness, and on the one hand, I watched some films before I came here, and on the one hand, he can hang back and be very, ho-hum, and yeah, I hear you, just very laid back seeming, and the next moment, very proactive. So there's this kind of surprise element all the time. You're not sure what he's going to do or say or how he's going to be. And he keeps you kind of on your toes that way. That's what I felt. And I'm sure that everyone who's interacted with him has felt that way, perhaps. But and that's what makes it so interesting. I also felt that he brings into the work so many other things, art, I think music, but nobody's spoken about music. But I think the tonality of the voices, the listening element, the matching the tone of the patient, or not matching it, the visual, of course, and literature and words, of course, and how they're expressed. And, I just wonder, I've heard often that it's often said that, good therapy should involve the arts. And I feel that very strongly here today. So a lot of art in therapy and a lot of arts in the therapy itself. And it's been really terrific. So thank you.
Hi, I'm Jenny. I'm also a student at William James, and Dr. Childs was my humanistic teacher. So I'm really happy to be here. I'm really grateful. I've enjoyed this conference very much, and in hearing, I'm very interested in what makes supervision effective, and in just listening to everyone's experiences with supervision, I'm getting a lot of images of secure attachment from an attachment perspective, especially when some of you have mentioned that he's with you in the room, like when you go into the waiting room and when you go into the room with the patient. And I'm wondering if you could speak to that, if that is in any way resonating with you, or if I'm way off track, and if so, either way, like, how so?
One of the things I would say is that Les had something he did both with patients and with his supervisees, where I use it sometimes with my daughters, and it's a statement, this is a tough one. I'm glad I don't have to make the decision, and it's a hard one. You've got strong shoulders, this kind of expression, you have these statements of confidence in immensely capable people who want the secure attachment of being with, sort of a mentor as you explore your new skills. But one of the things that's really important for supervisors, I think, is to just realize what Jennifer had just said about how young you all are, but how extraordinarily capable to find the solutions to the stuff you're coping with. So partly it's to stay out of your way, to encourage your curiosity, but also to be there to support you if things get really rough. You know, come in and take a little more responsibility. What do you think about that, Fern?
I mean, it does sound to me, I'm sorry, it sounds to me a bit like secure attachment and allowing the child to explore the world, but knowing they have a safety net to come back to if things go awry.
Yeah. So I think it's a good, I'm all for that.
Yeah, me too.
I think we should end the day on one of my favorite lines from Les, which is, what's the difference between the staff and the patients?
Pencils.
The patients get better.
And leave.
Good, you're right. Good to see you again.
Hello? Yep. So just in concluding, those of you who are looking for CEUs, check your email. I think you have to fill out the form and correspond with William James College. Finally, I just want to have all of you join me in thanking all these incredible people who traveled here to be with us today and really evoke the legacy of Les Havens.